Good afternoon, everyone. Welcome. I am Lucio Gordon, President and Managing Physician for Florida Cancer Specialists. We're here today as we're living through extraordinary and difficult special time with COVID-19, and we're trying to connect with all of you on the other side of the screen to discuss how we implemented telehealth and all the details related to its success at Florida Cancer Specialists. So, as you know, caring for patients in the time of COVID-19 has called on us to do things quite differently and very quickly. And we always had a dream of using telehealth or telemedicine, and we had to tap this unfulfilled potential very quickly. And we're thankful to CMS and insurance companies who have allowed us to do so, in a short time frame. So this evening, my colleagues and I will discuss how we deployed telemedicine across our practice in a matter of very few days, and how we have used telemedicine for more than 6,000 encounters since late March. Bringing telemedicine to our patients called for an enormous team effort across every part of our practice, from operations to information technology, billing, revenue cycle, provider training, nursing, legal, compliance, and everyone got involved to make this successful. We'll cover today how to bring telemedicine to patients quickly while ensuring quality care across practice sites and addressing the needs of patients being treated for cancer. Joining me today are Sarah Ceballos, our Chief Revenue Cycle Officer, who will discuss the reimbursement changes that helped drive the process. Ms. Laura Sperry, our Associate Regional Director of Operations, who will explain how training implementation unfolded at the office level. Mr. Mark Mock, our Chief Information Officer, who will discuss technology and patient privacy consideration in the process. And Dr. Michael Diaz, who will share insights into the process from a physician perspective. Dr. Diaz is the Assistant Managing Physician of Florida Cancer Specialists and President of Community Oncology Alliance. So without further ado, our first presenter will be Sarah Ceballos, and she'll discuss how CMS has lifted barriers to telemedicine and how changes in reimbursement have allowed us to use this tool across our practice sites. Sarah?
Thank you, Dr. Gordon. So good evening, everyone, or afternoon, depending on which time zone you're in, but really wanted to thank you for dialing in this evening and listening to Florida Cancer Specialists and our journey, which feels like a long one, but it's only been a little over a month of integrating telemedicine into our organization. So as Dr. Gordon mentioned, essentially our vision and what we've really been trying to integrate for the past several years is telemedicine into our organization, with the assistance of CMS as well as a number of our payer partners, as everyone is probably well aware of, releasing the regulations or loosening the regulations in terms of who can really get telemedicine has substantially been lifted and increased in our patient population throughout Florida, as well as throughout the country. So I'm not going to discuss or really provide any coding guidelines. I think there's a ton of resources and information out there. I'm not a certified coder, so I would definitely recommend that anyone who is looking for coding guidelines to essentially look on CMS's resource sheets. There's a ton of fact sheets and information available, especially by the payers. But really today I'd want to talk about kind of what it takes from a revenue cycle payer policy perspective, as well as integrating it amongst the practice throughout a large organization or a small organization as well. So when Florida Cancer Specialists first got the news, along with the rest of the country, there's obviously a lot of questions around what this means, who's eligible for telemedicine. As an organization, we really put the patients in the interest of our healthcare professionals first, and decided that whether payers kind of kept up with the reimbursement or not, we were going to just offer it across our entire patient population So as Dr. Gordon mentioned, there's been over 6,000 encounters throughout Florida so far, and that's rapidly expanding throughout our network as this becomes more and more popular, and as well as our providers and operations team get more and more familiar with how to integrate the patients into our telemedicine workflow. So we opened up the codes to all of our patients, payer agnostic from the get-go, and we really did an amazing really amount of orchestration across all departments. So as Dr. Gordon mentioned earlier in the discussion, it really took a huge team effort to get this going. So we started with obviously the codes that were available, got them integrated into our practice management systems as well as our EMR, and really were able to get a lot of information out to our network, which Laura will talk about here in just a moment, how operations was really to kind of get this going from a patient's perspective and a physician's perspective. But it really first started with kind of setting the information. We set a pretty comprehensive guide around the technology, and you'll hear from Mark here in just a few minutes related to the technology efforts that went on. But really wanted to make sure that we had very clear and very thorough information for our clinicians. And so while there's a pretty big subset of telehealth and telemedicine codes available, whether the patient has access to video or phone, we put a pretty simple guide out there so that way our back office billing team did a lot of the work, because obviously as everyone loves all of the different changes in the CPT codes, we wanted to make sure that it was very quick and easy, and we were able to provide the clinicians and the clinical team and the patients very easy, quick access to telemedicine, especially during this time. It was just a very rapid fire, and it still is. Everybody is changing, and all of the information is changing very quickly. So what we were able to do was, again, set this very basic kind of guide rule set in place that allowed the providers and the clinicians to just pick very simple codes and run with it, because it was really focused on patient care. So, we had, as this was rolling out in the physicians and the clinicians and patients were getting very much used to adding telemedicine to their day-to-day workflow. From the back office perspective, what we began doing was having a lot of conversations with our payer partners, particularly on the commercial front. And we started this conversation off with really just the discussion around how this has been our vision for a really long time. Obviously, telemedicine and the integration of how this affects not just cancer patients, but now cancer patients with an additional very complex disease, potentially, such as COVID-19, how this could really truly affect how cancer care and patients are treated in the long term, what that means to outcomes, what that means to our value proposition as an oncology, a very large community oncology practice. All of those things are things that we are beginning to now have really great conversations with our payers with. So I know a lot of the very large commercial payers, United, Cigna, Aetna, have been exceptionally responsive to this, and we definitely thank them for all of the flexibility in opening these codes up very quickly. I know CMS was one of the quickest ones out of the gate, which was nice, but I want to just kind of hat tip to those commercial payers as well for doing such a great job. And really, where does this stand for our future in terms of how we continue to provide value to our patients and continue to allow them to have access to these? So, I know a lot of the questions that I think about is, okay, well, when this is over and the patients are, more at ease to come into the office, are we going to take this kind of nice benefit away from them if it makes sense that they can access this? So hopefully not, and I think that, as an organization and as a community of medical professionals, we should probably continue to push that in the future. But as it stands today, I think the organization and the ability for us to now provide such an amazing service to our patients is just a phenomenal thing, despite what's going on. And obviously the complexities of being able to take care of the patient virtually, I know are something that, the clinicians and our operations team are going to continue to work through. But from a revenue cycle standpoint, along with our integration with our payer partners and the value that we want to bring to our patient population and to our just healthcare system in general, it will be phenomenal to see really where we go from here. So with that, I'm going to hand it over to Laura, unless Dr. Gordon, you have any further comments you'd like to make on revenue cycle.
No, Sarah, thank you so much. You have done a phenomenal job, and we have 800 team members in the revenue cycle team, and the way we were able to make this happen at the physician level, at the clinic level, it really made a huge difference in patients' outcomes. So we're extremely thankful to you and to your team. So as I transition to Laura, so Laura Sperry, again, she's Associate Regional Director of Operations in one of our regions, and when we had to manage COVID-19 practice changes, and everything came so fast and at once, including telehealth and so many other things, things would have been chaotic if it weren't for the leadership of special people like Laura Sperry. So, Laura, I'm going to pass the microphone to you here so you can walk us through the steps that made this successful story happen. Laura?
Great. Thank you, Dr. Gordon. So we were starting very quickly around the middle of March. We met with our IT leadership and put together workflows. That was the very first thing that we did. We met and we talked about how that flow would work through each of the practices and tried to standardize that. And as you can see, we quickly ramped up and are almost at 7,000 visits at this time. So that working together and making sure that happens. Some of the barriers that we've seen related to the telehealth is the patients just aren't comfortable just yet with the technology. So the patient's access and their understanding of the technology has really been a struggle. We've tried to encourage them to work with their family members to see how they can help get them through that process. Also, a lot of our patients just enjoy coming into our office. They enjoy seeing our physicians and our staff, and they feel like they're part of our family, as we do. And so we've had a few patients actually say, well, I just need to come in and see all of you because you're part of what I do every day or every week. So from a viability standpoint, it was really important for us to minimize the flow within our practices. So as we're all trying to be 6 feet away from each other, having every patient that's normally scheduled in our clinics there caused some concerns. And so it was nice to be able to bring just our treatment patients in and then give this option of telehealth to those patients that didn't need to come into the office. And that not only provided safety for those high-risk patients, but also for our staff as well and our physicians. So that's been a great benefit to the telehealth process. So just again, as we started to do this, we met with our IT group, again, put in the workflow situations, and then trained all of our staff. Our physicians and our office managers were the first to be trained, and then we did training sessions with our patient service specialists, those frontline phone answering, phone calling patient or staff. And then I think the biggest processes that we had to work through is just changes. And as we all know, with COVID, things have changed every day between the CDC and CMS. So just making those changes, being flexible, and then making sure that we were communicating that on a daily basis in a uniformed and consistent message to all of our staff has been probably one of the biggest and most important pieces of that. And then the communication, just mainly our physicians would review the schedules, get with our patient service specialist who would then call and talk to the patients, let them know what was really going on and what options we had to offer them. And then we also had waiting room monitors and flyers and printed information that we were able to provide also. One of the assets of this process has also been our centralized triage. So centralized triage has been able to call our patients. They've been able to talk to them about our policies and our procedures, how our check-in process has changed. We're asking patients questions and we're doing some reviews. So they've been able to give them that upfront information so that they're not surprised when they come to the office, making it much easier for us on the front line. As well as we have been able to leverage our behavioral health counselors and social workers so that we can offer that to all patients throughout the system for counseling and just making sure that everybody is comfortable with what's going on in their lives.
Thank you, Laura. Appreciate your comments here. So again, to the audience, feel free to send questions in the chat box, and we'll answer those questions towards the end of the presentation here. So we couldn't have done all of this if it weren't for Mark Mock and his team. Mark is the Chief Information Officer. And it was probably, I think it was a Wednesday evening, I called Mark or emailed Mark, said, Mark, you have 3 days to figure this out. And literally 19 hours, he, found the proper vendor that had enough, juice as far as the toolbox and security features that we could make this happen. So, Mark, we're very thankful for what you have done, and I'll have you run your part of your talk at this point.
Thank you very much, Dr. Gordon, for kind words. And like Sarah alluded and you already mentioned, I had a good head start up as we already were looking and evaluating telehealth product and vendors prior to COVID-19 pandemic. So our main focus really was rollout and adoption, and that was the biggest areas of opportunity for us. Specifically, how we train 500 plus providers quickly and effectively. How do we ensure that, everybody's proficient and we have a good company-wide adoption? And then from the patient side, of course, what is the actual patient experience going to look like? How do we roll this out to massive, patient population effectively? And with our strong organization support, and the true realization from the get-go that telehealth is a good solution, we've pretty much been very successful launching this solution. The main criteria we used to selecting the product in our process and the decision-making process was really, around compliance and security first, which is always the key for everybody. We want to make sure that we are protected. We want to make sure that all the traffic between the providers and the patients is encrypted, and that we're not storing PHI data on the vendor side, and we're trying to keep everything internally to FCS in our data center. And because of our situation and our patient population and the relaxation in the rules of HIPAA compliance throughout this pandemic, we still wanted to make sure that we are selecting the product that is going to be actually long-term solution, and it's not going to be, tossed away after this is over or our regulations are come back in play. We wanted to make sure that it's still compliant, that we're still doing the continuing this, and we actually can advance it more instead of going back and trying to figure out what now. So one of the points that we were looking at was, how much of an impact it's going to have on our internal resources. We want to make sure that it's not really resource intensive and we can roll it out quickly. So pretty much we're looking for the turnkey solution here to make sure that we can move forward fairly quickly. And then technology stack, of course, very important. We want to make sure that it's, it's a modern technology, cloud-based technology with easy delivery. We were looking in particularly for web RTC to make sure that there is no need to add any software and hardware for the end user, for our patients and for our providers. And then pretty much this solution can run natively in any browser. So you open your Chrome, your Firefox, your Internet Explorer, and pretty much you're in the session with your provider. And all you need is really a device with camera and a camera and a speaker. And additionally, we wanted to look at the solution that is, because of a modern design, modern technology stack, it's have an open API. It can integrate with another systems, as we were expecting that this is going to continue to grow, and we're going to want to integrate this with other systems down the road. So that was very important. And then on the feature side, it was very important for us to make sure that functions like virtual waiting room, where a provider can see the patient waiting for the telehealth visit, as well as the ability to add caregiver or or any family member to the virtual visit, especially in this situation here with the pandemic and COVID-19, is critical. We know in the cancer care, it's usually very important that that support person and ability to have somebody by your side is critical. And in the pandemic, in our social distancing environment that we are in now, the ability for provider to add family member to the same virtual session was critical. So we were able to accommodate this with this product. And then on top of it, of course, in like any modern system, we want to make sure that we can capture good metrics and get the real-time reporting out to our stakeholder on the behavior and how much we really utilizing the platform. Once we evaluated the platform, we settled what it's going to be for us. It was pretty much time to implement, so we immediately shifted to forming our implementation rollout committee. And then we started engaging business and clinical stakeholders, start finalizing all the agreement terms so we can move forward. And then we have to identify quickly what our internal personnel is going to look like. As Dr. Gordon mentioned, it was a really short period of time, so we had to really move quickly, considering the fact that we have to train approximately 500 plus providers, and we also extended this platform to level 1s for evaluations and educations and social workers and dietitians. It was really not a minor task, even just to provision those and set up and get rolling with this solution. It's a whole set of issues you have to address, especially in the timeline we had. It was really quickly. We wanted to just get it going. So our team had to tackle this, and at the same time, pretty much start preparing the training session for our users. So 2 teams were really critical in this whole process: our service delivery and our EMR support team, ICS team. And they were pretty much the key for the successful rollout. We went through very, very rapid internal training and built supporting resources for them. We created a telemedicine library for them in our SharePoint to make sure that everything is there when they need it. And we pretty much created all the guidelines for anything possible within the functioning telemedicine, like Sarah alluded to it before. And then, we created the guidelines pretty much for, how to set up your account, how to access your virtual room, where to look for the CPT codes, who to call when you need help, when you have to help patients set up before the telehealth visit. So a lot of work went into this. We choose to use the webinars and video trainings to get maximum number of providers quickly engaged in it. And we, at the same time, we recorded some session, pre-record some session, make them available in that library. So if anybody wanted to individually go in and look at the product, they could, and pretty much move forward. Through that short period of a time, I think it was like 4 days, we held a total of 127 individual trainings and 24 webinars. So it was pretty much very, very intensive training schedule for everybody. We were moving really quickly. We spent an entire weekend training our internal staff and providers. And to be honest, thanks to Dr. Gordon for support on this. The strong clinical leadership was key in getting providers engaged and getting providers on page with this and started working with us. And then on the other side, very important for us was what Laura mentioned here earlier. Working with operations made all the difference in the world here. We had to make sure that all the clinical workflows and what kind of an impact what we're proposing here is going to have on those workflows, and how we can tweak it effectively to where it's really workable and efficient solution for the physicians. So how we change this on the fly, and being really able to change this quickly for the environment, in our environment, really how we operate, it really made a difference on how it was perceived by the providers and how quickly we could react to some of those things. Just the agile nature of Florida Cancer Specialists as an organization really is the key, and the fact that we can do things quickly and we're flexible and I can really quickly adopt are really what made this very effective for us. And then speaking of the future of telemedicine, it's really just a quick note on, I feel like this is really a good medium or gateway for enhancing how we provide information to our patients. Our patients are getting more and more educated about what the results are, what the data looks like. So they're asking for this, and with current technological advancement and continuous of improvement of those deliveries to us, we feel like we're getting more and more full picture of everything that happens, not only throughout the visit and at the lab and radiology centers, but also, what happens in between the visits. So, we're already integrating devices like, we can integrate devices like home devices like blood pressure and testers, glucose level testers. We can record weight, eating habits, exercise habit by self-testing, pretty much self-reporting at home. So all of this in the future will become a part of the full-blown medical records for the patient. And feels like telemedicine helps lays that groundwork to stay engaged within the platform, and it helps to keep this drive towards this full picture of health and access to not only telehealth, but really all support systems as the patients becoming more and more educated around this. And really starts with simple improvement in how we deliver patient care to remote patients like now, but it shifts, in our case, it shifts really quickly to, all the care teams, and then eventually will shift into the full medical record within a bigger, complete platform. It also integrates well with all the changes and shifts in the reimbursement and value-based care models. As we already have a lot of requests and requirements being put in place for outcome tracking and self-report tracking.
Mark, thank you very much. It was a Herculean effort from you and your team to make this happen at Florida Cancer Specialists. So we're very grateful to you and to the rest of the team. As you may know, we have about 240 physicians and 260 plus advanced practice providers, and with different level of familiarity with technology, telemedicine, telehealth. So the next speaker will be Dr. Michael Diaz, who will offer insights on how the physicians at SCS and other places that he's aware of have embraced telemedicine in our institution. Dr. Diaz will be our last speaker, and then at that point we will I have received quite a bit of questions here, and I will throw them around to the other participants here so we can address them. Dr. Diaz?
Thank you, Lucio. Thanks for the introduction. And first of all,
Sure.
I'm going to apologize. I'm getting used to using these cameras and the microphone on these devices. So if my device is freezing up on me, I apologize. I thought I had all the settings working, but I think it might be stopping every now and then. So it highlights one of the things that we're having to get used to as we adapt to this technology. And I think it's freezing up on me again. Hopefully,
It's
you're
working
hearing me
well.
while
Go
I'm
ahead.
going through this, though, aren't you?
We can hear you.
It's all
Okay,
good.
it's working out. Okay. Okay. So nonetheless, this has really been an interesting experience, and it's been pretty much mind-boggling about how fast all this has evolved and how quickly and efficiently our team works at being able to allow us to provide healthcare in this fashion. I mean, first of all, whenever we really have to implement social distancing in our clinics, which meant we had to keep traffic down to a minimum. We were only scheduling the patients that really, truly, absolutely needed to be here. We're focusing mainly on our patients undergoing active treatment. And, as far as I'm concerned, that's not always going to be the best population with which you may want to do telehealth visits. If they're coming to the clinic anyway, as long as everything else is okay, you should go ahead and see the patients while you can, because there's lots of things that need to be monitored with a physical exam that you can't as easily do with telehealth. There are some things you can do with telehealth. It's just not as good as being there with the patient. And so usually patients that are undergoing active treatment in the clinic, we will typically want to see them routinely. Now, if they have something that pops up in between their normal treatment visits, as long as, patient seems like they're stable enough, then sometimes we can handle those in between treatment visits with a telehealth visit. And so, I guess you could say, as long as you're seeing the patient frequently enough, if there's just a question, if they have a new skin lesion that they can show on a camera, if they have a sore in their mouth, they can show on the camera, if they want to go over some acute side effects that they might be having, that actually might be an appropriate patient for a telehealth visit, as long as they're feeling well and they're stable. That's a good example of someone you could have a telehealth visit with. Other patients that, new patients exams, new patient consultations, within certain constraints, you can do telehealth visits with those. I mean, personally, ideally, if the patient can come in and it's safe, a lot of my partners and I, we tend to still like to at least see them the first time, but that's not always possible. The patient may have other medical conditions which may prohibit them from actually getting out to the clinic unless it's absolutely necessary. So sometimes you can use telehealth visits for initial consultations, because a lot of what we do involves educating the patient and talking about things and discussing laboratory findings and or discussing radiology results. Then sometimes after my initial assessment, the first visit or two after that, it might actually be a telehealth, because we're spending a lot of time talking and discussing. That is, as long as the patient doesn't have any acute or is not stable, or they don't have any acute conditions that need to be very closely monitored by examining the patient with a physical exam. And so a lot of the educational sessions that we do have with our patients, I've been providing with telehealth, and it's actually been working out fairly well. Patients, a lot of hematology patients with follow-up, as long as they have appropriate labs done beforehand, then those might be good examples of patients you might want to schedule for a telehealth follow-up. Some of your other patients, though, that are 3-month or 6-month or annual follow-up visits, we sort of, if at all possible, delaying their visits just, a couple of weeks, couple of months, as long as they're stable, so that we can have the opportunity to do the exam. Patients that you're following for breast cancer, they need to have a breast exam. You have to be able to examine the chest wall, the axilla, the breast. And so, once again, we have to address it on a patient-by-patient instance as to whether or not a telehealth visit is appropriate. We find that some patients are adapting really well and quickly to this type of interaction, and it's actually worked out extremely well in a lot of scenarios. Patients are finding that it's actually easier than having to get into a car and drive to the clinic and park your car. So it's working out well for some patients. Some patients are technologically challenged, and that they are shying away from a telehealth visit, and they're opting for a telephone visit. And they start talking about, well, I've got a sore in my mouth that you need to see, and then we're actually able to just talk them into, okay, let's try this via telehealth. We can talk the patient through the visit and manage it via telehealth. So it's, I guess you could say, interesting growing on both sides, but I think that it's actually working out fairly well. It's doing a significant job of improving, I think, our safety in the clinic by decreasing the amount of traffic in our clinic. That's one thing. And the other thing is that a lot of doctors are also using this as patient hospital visits, using telehealth. Why? Because if you're not going into the hospital, you're reducing your own personal exposure to patients or to COVID, to the coronavirus. And so if we as healthcare professionals ourselves COVID-free, then we're helping keeping our clinics COVID-free so that we can keep it COVID-free patients who need their treatment. And so we're starting to see a lot of adaptation with this to minimize trips and visits to the hospitals. Obviously, not every patient can be managed, an inpatient with telehealth, but a lot of patients can. It also involves a lot of coordination with the referring doctor. Let's see. Sometimes if the patients find that it's difficult to use the software, then we're just using FaceTime preferred, but we can use FaceTime or we can use Google Duo. There are other ways that we've been able to have our telehealth visits, but I think that it's been working out very well for both the physicians and the patients. It's definitely helping us get through the, I guess you could say, this rough period of growth of the coronavirus. So we start to calm down, hopefully. Well, we can slowly integrate more patient visits back into our day. But I think we're going to have to have distancing for some time. A lot of this is to be determined. And so I think that this will be, I guess you could say, the standard of care here for at least the next foreseeable future.
Thank you, Dr. Diaz. Any more comments from you? All right, I'll carry on here. Mike may be frozen in addition to the camera. So real quick, I have a list of questions that have been sent by all of you on the line here, and we'll try to answer in the order received here. So the first question is for Sarah or Laura or both. Who did you need to engage to make something as big as this work?
I can start, I guess. I think a lot of what you had, kind of the folks here on this call, were probably the biggest people that we really had to engage. So, we're really the spokespeople for a lot of team members who work with us. And we have, a number of coders, number of billers in my organization. Laura obviously has, a ton of people who work with her. And we just really came together as a team. We think, like Dr. Gordon, we had 2 calls a day. Telehealth alone, probably, Mark and I and our ICS team, our EMR team, were exchanging, chats at 10 p.m. at night. I mean, it was just a huge orchestrated team effort in order to get this done. We really use a lot of our internal resources, obviously a lot of reading. We definitely relied a ton on experts like, Bobby Buell, who's providing ongoing guidance. I mean, she's just done a phenomenal job from a reimbursement and coding perspective. But a lot of the decisions that, we make as an organization really do come as we collaborate together. Just hearing all of the various team members, their perspectives in their business areas is just a huge part of how we operate and our culture, and just part of our DNA. And so I think just in terms of bringing together all of our, resources, and obviously there's a ton of information online in the community that we've, relied upon too. But I think from the perspective of resources and who we brought it together is, I would just say it was definitely a coordinated event. I don't know, Laura, if you have anything to add on that.
I agree with you, Sarah. I think it was everyone. And it was once we started implementing, listening to the physicians' feedback, listening to the staff feedback, and then making adjustments. And most of all, communicating all of those adjustments out in one single message, I think was a huge bonus for us in the process.
Absolutely.
Thank you, Laura. Thank you, Sarah. Other question here, maybe Sarah and I can take this one here. How does the 6,000 encounters to date compare to the same time pre-COVID? So when the crisis hit, and since the crisis has hit us in the whole country, we have seen a drop of new patient volume in the order of 20 to 30%, and new patient return about the same magnitude. Infusion-wise, we have seen a drop in about, let's say, 10, 12% or so. So the 6,000 encounters by telemedicine have helped changing the angle of the slope of the curve. We're going downhill very quickly. Patients have no access because, or decreased access. Of course, they could come to the clinic and see us, but there was increased risk for several reasons. But so the telemedicine has really helped us kind of start getting up and moving more and more. We're seeing now new patients, return patients, and more often. So 6,000 is a good beginning, I should say. It hasn't corrected the problem. Sarah, any comments?
Yeah, absolutely. I think obviously the challenge that the practice faces, the operations team faces, and making sure that the patients are coming in safely is really the top priority. So, while there's, obviously this decreased productivity or, volume, I guess, of services, we're really kind of focused on making sure that the right patients, to Dr. Diaz's point, are being seen in the clinic. So I think the priority of making sure that those high risk patients that really need to be seen were the biggest priority. But yeah, from a productivity loss, I think in all of, probably across the cancer health system, it's kind of everyone is in the same boat. So.
Thank you. The other question could be for Dr. Diaz and myself. What type of patient support materials are you providing when you do telehealth? So you see a patient in a telehealth encounter and there's a question. Are you emailing the patient information about their chemotherapy treatment plan? Are you mailing via snail mail? How are you handling something that you would easily do differently in the clinic, such as printing something and giving to the patient? How are you handling this, Mike?
It depends on what type of information is being needed for the patients. Sometimes if it's information that can be very easily or quickly emailed to them, then we'll have the front staff do it. We'll have it printed off and emailed to them. That's usually probably, if they want a permanent copy, that's probably one of the better ways to do it. Sometimes whenever I've been going over things with them, such as the NCCN guidelines, and sometimes I'll just share my screen. And then, if they want a copy of that, then we can email it to them later. So I usually have the front staff work with the patients on that. So it's a case-by-case basis.
Thank you, Mike. I practice the same way. I usually, try to share my screen as well to see the labs or scan reports. I use email quite a bit. To communicate with the patients even before the COVID-19 crisis started. So secure email, of course. And but I haven't seen any major impediment as far as transference of knowledge from us to the patient because of telehealth. Telehealth actually has really been helpful in that arena. Next question is for Sarah. I have read that some payers are frustrated with payment of telemedicine services. Have you encountered this?
Frustrated? I'm not sure what that means. Frustrated, but I haven't heard any pushback from payers in terms of not being open to pay for telehealth. I think at least from the payers that I've had conversations with, everybody is very optimistic. They're actually very supportive in terms of protecting our healthcare professionals and their patients. So I think it's been really great, but I haven't heard any frustration just yet. I know as many people have, experienced probably on this phone call, some of the challenges associated with making sure that reimbursement is actually, or the payer systems are up to date as the codes are changing. That's probably one of the biggest challenges we're going to face is as far as reimbursement goes. Because anytime there's some type of a CPT code structure change or difference in place of service or any type of just billing change overall, a lot of times we see that there is that disruption in just terms of making sure that the payers systems, technology systems are up to date and just fast enough for reimbursement trends. So we've actually, from a Florida Cancer Specialist perspective, have really just sent batches of our telehealth claims out just to test them to make sure that the payer systems are ready, as well as before we submit the codes, actually physically contact our carriers and say, okay, this is how we're doing it, because they're changing them on the fly. We are just submitting, I think Laura mentioned this earlier, we're just doing, I think, our third version of our guide and our coding updates actually this week. So because of payer changes. So we just can't keep up fast enough. There's definitely a lot of late night reading going on. So as we go to submit the claims and the reimbursement, we are being proactive and trying to make sure that we send out small batches because we have such high volume. And as much as it pains the physicians and the business to wait for the payment, we'd rather wait for the technology and the billing structure and the platform to be ready before we submit the claim, because resubmitting is even harder work. So I think from a frustration standpoint, maybe that's what they're referencing. But I would definitely just, what we're doing is just keep, working with your payer rep, your provider rep to make sure that they're ready for the claims to come in.
Thank you, Sarah. I'll give you and Dr. Diaz a short break here. So the next question will be for Mark. Mark, in your opinion, what were the biggest challenges as far as the integration of telehealth into the EHR?
Yes, so our main focus was, how we can deliver the platform quickly and we can start treating the patients, considering that all of this closing happening really quickly and we're all going to stay in home very soon. But the main focus was get this functional and operational to where we can start working with the physicians and the patients on the training and making sure that we start moving. As far as the integration works go, this is still ongoing for us. We're now evaluating how this is all going to get integrated with the scheduling and the rest portions of the EMR we would like to do this with. And additionally, of course, the most important thing is, what kind of a capability platform have and how we're going to be able to leverage this with what we have on our side as well as on EMR side vendor, but all critical components to make sure that this works. And additionally, we will be looking to how we can roll it up into the bigger platform for our patients so we can have pretty much one place for the patient to go and go get their telehealth visit, their lab result, everything else that needs to be happening around their care. So the biggest challenge is really to make sure that you partner with somebody who can do things quickly and they have modern technologies to integrate systems. That's the biggest key. And we think we have it with Doxy.
Excellent. Thank you. There's another question back to Sarah and Dr. Diaz, if Dr. Diaz is back online. This is a question that has come from multiple audience members who are asking about the future of telemedicine post-COVID-19. Do you have a gut feeling what CMS and the private payers will do? Are they going to keep paying for the as far as reimbursement? Are they going to cut reimbursement? Are they going to tell us to take a hike? What's in your mind?
I think it's one of those situations where if you give somebody something, it's really hard to take it away. So it will be really interesting to see what the payers do. I think they'll probably, if I were to put my magic, 8-ball kind of, channel my magic 8-ball here, I think they'll likely open it up a little bit to some more flexibility than it was before. Instead of just being completely cut off, I think they'll likely put some barriers around it, which I feel would probably be appropriate, because there are patients that I think, clinically speaking, Dr. Gordon, you could probably attest, do need to come into the office. But I think it should be left up to the physician to make those calls to do that. But I would anticipate if, I know I'm leaning towards, we've been trying to negotiate with a lot of our payers, and we were only able to get one private payer to open it up to us before the pandemic. So I'm glad it's not that it came this fast and rapidly, but at least there was a positive outcome to it, and will be hopefully for the long term. So I'm optimistic that they'll continue to pay for it.
Me too.
I'll have to agree with Sarah. They sort of opened up Pandora's box. It's difficult to close it. I think that the American public would be extremely dissatisfied if you took telehealth away from them. I do see that it will probably continue to have constraints as things evolve. May have a few more regulations around it as well. But I think that it's here to stay. It's just a matter of making sure that we're using it wisely and using it appropriately for patients, because nothing replaces altogether entirely. You cannot replace the face-to-face clinical visit. So those are my thoughts.
Makes sense. Now, let me put you on the spot. Since you're the president of COA and a leadership at ASCO and Flasco, Mike, will COA advocate for continuation of telehealth in the future?
If there looks like there's any risk of losing it, I can guarantee you that, COA will advocate for it, because I think we're demonstrating that it's the best thing for the patients in some situations. Their lives, just like ours, are filled with a lot of regulatory burden. If it's a visit that can be managed very adequately, with a telehealth visit, I just really don't see why patients shouldn't have that option.
Good. This is a question for whoever wants to take it. What is the role of the pharmaceutical industry in this evolving space? Any comments? I can take it while you guys are thinking. So I think the way I see pharmaceutical companies working with us in the telemedicine space is primarily with educational tools. If we're able to help patients understand about their disease processes, about a drug treatment, combination treatment. I think if there are tools that the pharmaceutical companies can help us with, as far as hyperlinks or whatever we can come up with that is educational, that's how I see them being part of this solution. Any other comments?
Yeah, I would echo that, Dr. Gordon, and I would even kind of give a shout out to Genentech, and I don't know if any of those folks are on the call here, but even from an education standpoint, from the patient's perspective, but also from the back office, clinical and operations perspective, they've already started to do technology-based tele-education on their drugs and some of the disease states, which is extremely beneficial. So really appreciate, pharmaceutical companies extending that offer during this time. Speaking just from the revenue cycle perspective, as you mentioned, we have about in total about 800 or so team members that are sitting in their home offices, most of them probably at their kitchen tables trying to follow up on claims because of the situation that we have. And being able to, cancer doesn't stop. The doctors are still treating all of the patients. We have to keep up with the indications just like the physicians do. So we really, I know this is really focused on patient education, and that's certainly something that, we can leverage from a telehealth perspective, but giving the opportunity for the offices and the administration staff to be able to have that education too has been extremely beneficial. So if we can continue to use this type of technology moving forward, even if they can't come into the office physically, I think that would be extremely valuable for everybody.
Thank you, Sarah. Another question that has come a couple of times here, I think Laura could tackle, or maybe Dr. Diaz as well. What challenges have you had with patients using DoxyMe platform? And just a disclaimer, we do not have anything to do with DoxyMe. We are a user like anybody else, so we're not making advertisement, but it works really well. But Laura, any concerns, patients complaining, any challenges?
We really haven't. The technology is very user-friendly. It's pretty one click and you're in the waiting room waiting for the physician, as well as the physician clicks to start the call. It's very, very user-friendly. I think they've put in some specifications where patients can actually check to see if their settings are correct prior to the call. Again, I think our barrier is just a population that is either not ready to use the technology or just doesn't have it in their hands. So I think that's probably from my perspective, the operations perspective, that's where we see the biggest stumbling.
Yeah, I'll have to agree with Laura on that one.
Oh, go ahead.
Yeah, I'll have to agree with Laura. The only time I've had a significant issue, I've had a couple of examples where patients don't know how to turn on their microphone. And so I can't hear them. They can hear me. I can see them, but I can't hear them. And so sometimes, yes, we'll do the video, and sometimes I might need to actually call them. But that's probably about the only significant issue that I've seen, and that's very rare that happens.
I agree. I had a situation today that I had to pick up the phone and call their home phone to let them know you have to turn on this button here to get the volume up so you can hear me. But 5 minutes later, we got it. It was a fun visit. This question could be for any of us here, but I can take it. What have you found that works and does not work as a leader to encourage adoption of telehealth? So I think like any leadership decision or process, it's all about communication times 100, transparency times 1,000, and make sure that we have proper educational materials. As Mark said, he did 127 one-to-one training, I think 27, 24, something like that, webinars. So again, communication, transparency, being available, and actually doing what the frontline people are doing. Both Dr. Diaz and I are practicing physicians, and we see patients frequently. So I think being, everybody's having skin in the game, it makes a big difference. Another question here. I may make this the last question because we're at the top of the hour here, and we will make this last question here. I'll make some closing remarks. Mike, I'll give this to you. Would you expect to see a bolus of late-stage patients showing up, let's say in September, October or so, because they're not being seen, or they're missing screening tests, or they're just not getting to see their primary physicians and specialty physicians? What's your opinion?
Unfortunately, yes, because of the delay in screenings, because of the delay in getting diagnoses. I unfortunately think we're going to see more advanced cancers present in the third and fourth quarter of this year. It's as one could intuitively expect, but that's just what my gut's telling me. I mean, they're not even allowing elective colonoscopies to be done. So nonetheless, I think you're just going to, and then there's going to be a backlog once, the facilities start doing their diagnostic procedures, tests, and studies. So I think we will see more advanced stage cancers diagnosed.
Yeah, I think it makes a lot of sense. I was working with a group to try to model this for us so we can understand what will happen in 6 months, 12 months from now, but hopefully we'll get some data. So I would like to, before I close here, I'd like to thank AJMC very much for the opportunity of speaking on telehealth to this large audience from all over the country. Thank you, Mary Caffrey. Thank you, Lindsay McKay, for the technical and non-technical help with everything related to today's event and to other events we have done together in the past, and hopefully we'll do in the future. And I would like to say a big thank to all of you in the audience on behalf of Florida Cancer Specialists. I know we have just 1 hour today, and if the questions remain that we'll be always happy to try to address, you can connect with one of us or AJMC, and we'll try to get an answer to help community oncology at large and help increase access of patients to proper care. I wish you a very good night and stay strong. Thank you very much.